afternoon all. So last class we have discussed the basic principles of ADME, that is absorption, distribution, metabolism. So now we will be moving to the last part of ADME, that is excretion. So first we will see the definition for excretion. So that is, excretion is the passage out of systemically absorbed drug. Here excretion we can explain like, once the drug is entered into the systemic circulation, the process is called absorption, and after absorption the drug undergo distribution and metabolism. Finally it is irreversibly lost from the body, and that process is called excretion. Then next we'll see the difference between elimination and excretion. So elimination is a broader term which include excretion. So elimination can be done by metabolism or excretion, and excretion is the irreversible loss of drug from the body. So next we will move to the main route of excretion. These are kidney and the biliary system, and the minor routes include exhaled air, which is mainly done by lungs, and then saliva, sweat and milk. Next, we will move to renal excretion. So, the excretion is mainly divided into renal and non-renal. From the name itself, we can understand renal excretion is mainly done by the main excreting organ of our body, that is kidney. So, here mainly water-soluble substance are excreted from the body. So, we will give a definition to net renal excretion. So, that is equal to glomerular filtration plus tubular secretion minus tubular reabsorption. So we can tell there are mainly three mechanisms for renal excretion. These are glomerular filtration, active tubular secretion and passive tubular reabsorption. So the figure shows the basic structural unit of kidney, that is nephron, and we have mainly glomerulus, proximal tubule, distal tubule, loop of Henle and collecting duct. So first we will see the first mechanism, that is glomerular filtration. So once the blood reaches the glomerulus, the blood is filtered and it reaches the proximal tubule, where there happens two mechanisms, mainly active tubular secretion and active reabsorption. So we can say active tubular secretion is opposite of active tubular reabsorption, which means secretion is the movement of substance from blood to the renal tubule, and reabsorption is the movement of drug from renal tubule to blood. So the final eliminated product which will be reaching the collecting drug will be the sum up of glomerular filtration and active tubular secretion product. So only the reabsorbed drug will be moved into the blood, other will be eliminated from the kidney through urine. So we will see this mechanism in detail. So first one is glomerular filtration. So we can say it is a non-selective unidirectional process, and the main factor which affect the glomerular filtration will be molecular weight. As you all know, plasma protein binding, the drug will be bind to a plasma protein which will increase the size of the drug. So the molecular weight is a major factor which affect glomerular filtration. So as the molecular weight increases or the molecular size increases, the drug will be difficult to filter through glomerular filtration. So we can conclude that all unbound or free form of drug is easily filtered through glomerular filtration, and the normal GFR is approximately 120 ml per minute. Then we have active tubular secretion. So this active tubular secretion, we have mainly two transporters, that is organic anion transporter and organic cation transporter, and this organic anion transporter helps in the secretion of organic acids or anions, and examples for drugs that are actively secreted through OAT are penicillin, salicylic acid and uric acid. And next we have organic cation transporter, which helps in the secretion of organic bases or cations, and drugs which are secreted through organic cation transport are cimetidine, quinine and procainamide. So next we will be moving to the next mechanism, that is passive tubular reabsorption. So in our body there are mainly two mechanisms, that is active tubular reabsorption and passive tubular reabsorption. So active tubular reabsorption is mainly done by, or mainly it undergoes through natural substances which are present in the body like sodium, potassium, glucose, etc. Then passive tubular reabsorption are mainly for drugs, or we can say the exogenously administered substance. So drug is an example for exogenously administered substance. So the main two factors which are responsible or which affect the passive tubular reabsorption will be, one will be concentration gradient. So the movement of the drug will be from lower concentration to the higher concentration. The next will be lipophilicity. If a drug is highly lipophilic, means the drug will be more able to secrete it through the transporter. So this principle we can be used for poisoning. That is, when a drug, like if it is an acidic drug, then we will alkalize the urine using sodium bicarbonate. So the drug will be alkaline and the drug will be eliminated easily from the body. For in case of poisoning with a basic drug, we will administer acidic drugs so that the medium will be acidic and drug will be easily eliminated from the body. Next we will be moving to factors affecting renal excretion. As I have said, the main factor will be molecular weight of the substance. So physicochemical properties of the drug. So we will give more importance to molecular weight. So drugs which are having high molecular weight will be difficult to pass through the glomerulus, and only low molecular weight substance will be filtered through kidney. Next, binding characteristics of the drug. So unbound or free drug are usually filtered through glomerulus, and plasma protein bounded drugs, due to its high molecular size, there will be a restriction to the glomerulus and it will be retained in the Bowman's capsule. Next, biological factors. In biological factor, first we will see sex. So here renal excretion will be 10% lower in females than in males, and when we consider age, the newborns, in case of newborns, metabolism excretion will be low, so that the drug will be difficult to eliminate and excrete from the body. And in case of elderly patients, they will be receiving many drugs, as you all know, and also they will be under many medical conditions which will hinder their elimination and excretion process. So the drug will be resident on the body for many times, and patient will be more prone to toxicity. So the last point is disease state. In case of renal dysfunction, now we are discussing renal excretion. So the main excreting organ is kidney. So in case of renal dysfunction, the kidney is unable to filter or remove the waste from the body, as it has some disease condition, mainly uremia or accumulation of fluid or protein metabolite. In that case, drug that chooses the renal excretion pathway will not be able to eliminate from the body, and it will be retained in the body and cause toxicity. So next we are moving to non-renal excretion. So we have fecal and biliary excretion, pulmonary excretion, salivary excretion, mammary excretion and dermal excretion. So first one is fecal and biliary excretion. So in renal excretion, the major factor that is affecting for renal excretion will be molecular weight. So there are substances that have more molecular weight. So that will be eliminated from the body through biliary system. So we can say molecular weight greater than 300 will be most probably eliminated from the body through bile. And examples for drugs are ampicillin, erythromycin and tetracycline. Next, here we have another mechanism, that is enterohepatic circulation. In one word we can say it is the circulation of drug from the liver to the bile followed by entry into small intestine and are carried back into the liver. So the drug will be circulated in the body through various organs. So in that case, drug will be resident in the body for long period of time, and it helps in the prolonged use or prolonged exposure of drug to the body. So here, the drug will be first reaching to liver for metabolism, and it will be conjugated to one or the other pathway, and this drug conjugate through bile will be reaching to small intestine. In small intestine, we have many bacterial conjugases, and this bacterial conjugases will degrade the drug conjugate into drug, and the conjugate will be eliminated. This drug again will reach the portal vein and again reaches to liver. So we can say it is a cycle which repeats in the body for a long time. So the drug will be resident or drug will be present in the body for a long period of time, and it helps in the prolonged use of drug in the body. So here the bacterial deconjugase, once we administer antibiotic or some other drugs which will alter the bacterial deconjugase, that is bacteria usually present in our body, these bacteria will be degraded and then this process will be eliminated, or this process is affected mainly based on the antibacterial drugs we have administered. So this process is a naturally occurring thing in our body, and the main hindrance or the affecting factor will be the antibiotic administration, mainly amoxicillin, streptomycin. Next is pulmonary excretion. So these are the main route of excretion of gases and volatile liquids. So here the main factor affecting pulmonary excretion are pulmonary blood flow, rate of respiration, and solubility of the volatile substance. So pulmonary blood flow, if the blood flow is more, excretion of drug is more, and rate of respiration is an important factor for the elimination of drugs through pulmonary excretion. So once the respiration rate is more, then excretion of drug is more, and solubility of the volatile substance. Volatile substance, once if it is soluble in blood, it will be remaining in the blood for longer time, and drug will be resident in the body for long time. So decrease in solubility increase the amount of drug secreted through lungs, and gaseous anesthetics such as nitrous oxide, which are not very soluble in blood, are excreted rapidly. So the drug which are not soluble in blood. So if the drug is not soluble in the blood, means the drug from the blood will be passing to the lung or alveoli, and the elimination process will be more easier for the drug. Next is salivary excretion. Saliva is a minor route for excretion of drugs. So the pH of saliva will be 6.4, and the unionized lipid soluble drugs which are unionized in 6.4 pH, that is the pH of the saliva, will be eliminated through saliva, and examples are metronidazole, disulfiram, and metoclopramide. Next one is mammary secretion. So here the mammary excretion will be not so much significant to mother, as it is more affected by infants, because during breastfeeding the drugs which can pass to the alveolar duct or mammary gland, it will reach the infant body. As you all know, infants have less eliminating and metabolizing capacity. So once the drug reaches the newborns, it will be resident to the infant body, and it will cause toxicity more than mother. So we can say it will be less insignificant to mother than compared to the fetus. And less protein bound drugs, that means plasma protein bound drugs will be highly molecular weight substance, so it will not be able to pass the mammary duct and crosses the alveoli. So that drugs will be safe for to